Antenatal care lecture. Listen at 2 times, 3 times, once a week, and you will memorize it. So, antenatal visits. Idle visits, 12 to 15 visits. So 0 to 28 weeks, then 38 weeks, and childbirth. So, for the first 0 to 28 weeks, is almost 7 months. You need 1 visit per month. After that, 1 visit per 2 weeks. So 2 visits per month until 36 weeks. 36 weeks is almost 9 months of the beginning of the 9th month of the pregnancy, so till 8 weeks, and then 1 visit per week until childbirth. Minimum number recommended by WHO is 8 visits. First trimester, first visit, 2 visits in second trimester, and 5 visits in the third trimester. Minimum number of recommended by Government of India are 4 visits. First visits within first 3 months, second visits 14 to 26th week, and third visit 28 to 34 weeks, and fourth visit 36 weeks to birth. First antenatal visit. Investigation done. ABO RH status. If RH negative female, check husband's RH status. If RH positive, indirect Coombs test at first visit. Repeat at 28 weeks of gestation. Complete blood count plus hemoglobin. ACOG guidelines, repeat hemoglobin testing at 24 to 28 weeks of pregnancy. Indian guidelines, repeat hemoglobin at all 4 visits by digital hemoglobinometer provided under Anemia Mukt Bharat program. Urine microscopy in all trimester. High risk for asymptomatic bacteriuria, diabetes, sickle cell anemia. Also do urine culture and sensitivity. ACOG guidelines. HIV, opt-out approach on patient refusal to test. Screening test, ELISA. Diagnostic confirmatory, Western blot. HBsAg testing regardless of vaccination status. VDRL test, RPR. Diabetes testing as per DIPSI guidelines. First test at first visit, second test at 24-28 weeks of gestation. Optional investigation, thyroid stimulating hormone, aneuploidy screening, rubella susceptibility test, IgM negative, IgG negative. Patient is susceptible to rubella. Vaccination after delivery. Rubella vaccine, live vaccine, contraindicated during pregnancy. So MMR is contraindicated during pregnancy but can be given after birth because it's a live vaccine. We give pertussis vaccine during pregnancy, and varicella and MMR before pregnancy or after. National guidelines does not recommend routine torch testing. ACOG recommends Group B streptococcal testing in all pregnant females between 35 to 37 weeks. Sample rectovaginal swab. Vaccination, TD. Tetanus diphtheria toxoid vaccine, TD at first visit, TD2 after 4 weeks. In Canada, they give TDAP, which has pertussis as well. If pregnant female received complete TD vaccination within the last 3 years, only TD booster in current pregnancy. So here is the TDAP, tetanus diphtheria acellular pertussis vaccine. Single shot between 27 to 37 weeks. Single shot, and it is recommended with each pregnancy. Identification of high risk pregnancy. High risk factors: extremes of age, less than 20 years or more than 35 years is high risk. HIV positive, HSBAG positive, severe systemic illness, severe anemia, less than 7 hemoglobin, hypothyroidism, multivital pregnancy, placenta previa, malpresentation, bed obstetric history, preeclampsia, gestational DM, previous history of C-section, any pregnancy complications. Color coding of antenatal card. Color on card, risk factors. Green, no risk factors. Red, high risk. Blue, pregnancy induced hypertension. Yellow, comorbid conditions. So green and red are very easy to remember, but this is new. Blue is hypertension and yellow is comorbidity, maybe DM. As per Pradhan Mantri Surakshit Matritva Abhiyan, only two colors, green and red. No risk factors, red, high risk factors. So high risk factors has 3 additional antenatal visits advised. Alert signs and symptoms. Patient to be advised to visit hospital if she has or develops fever more than equal to 38 degrees Celsius for more than 1 day, persistent vomiting, headache, blurring of vision, generalized edema, puffiness of face, discharged bleeding per vaginally, abdominal pain, decreased fetal movements, breathlessness at rest. Folic acid supplementation to prevent neural tube defect. 400 microgram per day prophylactic dose given to all pregnant females. Begin at least 1 month before conception, continue till 3 months after conception. To prevent reoccurrence of neural tube defects, 4 mg per day therapeutic dose given to females with previous history of neural tube defects. Begin more than 3 months before conception, continue till 3 months after conception. So prevention is 400 microgram, therapeutic is 4 mg. RDA in pregnancy, 500 microgram per day. Special cases. Diabetic females, prophylactic dose 400 microgram per day. Patients on anti-epileptic drugs more before conception 400 milligram, after conception 4 milligram. Sickle cell 5 grams. To treat megaloblastic anemia 1 gram. Note: 4 months onwards, iron plus folic acid supplementation as per Anemia Mukt Bharat program. 50 milligram elemental iron plus 500 microgram of folic acid, red colored tablet, 1 tablet per day given to prevent anemia. To prevent females with anemia, continued throughout pregnancy or for 180 days of pregnancy, plus 180 days after delivery to replenish iron stores. 2 tablets per day given to treat anemia to pregnant female with anemia. Assessments in antenatal visits. In each antenatal visits, weight, blood pressure, look for pathological edema, uterine height and fundal height, auscultate fetal heart sound with Doppler with stethoscope, urine dipstick for proteinuria, glycosuria. Between 24 to 28 weeks, hemoglobin percentage hematocrit by ACOG guidelines, GDM by DIPSI guidelines, indirect Coombs test if Rho negative at 28 weeks. Nutrition and pregnancy. Females sedentary 1800 calories, moderate 2100, heavy work 2700. Additional requirement in pregnancy, average plus 350 kilocalories per day. TI does not require additional calories. National T1 does not require additional calories. Trimester 1 plus 85, 2 plus 280, 3 470 kilocalories per day. So in trimester 3 you have to eat one more time. Weight gain. Normal 11 to 12.5. BMI, if it's normal, then you can gain up to 11 to 12.5. If it's low, then you can gain up to 18. Recommended weight gain, obese only till 9 kg. Consequences of decreased weight gain: small for gestational age baby, small for gestational age baby. Consequences of increased weight gain is hypertension, pregnancy induced hypertension, macrosomia, failed induction, C-section. Factors affecting weight gain in pregnancy: socioeconomic status of patient and weight gain. Parity is directly inversely proportional to weight gain. Ethnicity: pre-pregnant weight and weight gain is directly proportional to weight gain. Smoking does not affect weight gain in pregnancy. Other nutritional requirements: calcium, RDA is 1000 milligrams, iodine, RDA is 250 microgram, given as 2 tablets from 4th month onwards. Minimum duration between calcium and iron dosage is 2 hours. Protein, average additional supplement plus 45 gram per day. Trimester 1, no additional requirement. 2, 10 gram per day. 3, 20 gram per day. Vaccines in pregnancy. Live vaccines are contraindicated. Killed vaccines are not contraindicated. Minimum period for before pregnancy for safe administration of live vaccine is 1 month. Less than 1 month not indication for medical termination of pregnancy. Contraindications in pregnancy vaccine: MMR, which is given while they are trying to conceive; smallpox, chickenpox, BCG, HPV. HPV is not a live vaccine, still contraindicated. So this is very important. Vaccines not to be given while pregnant: MMR, smallpox, chickenpox, BCG, HPV. Safe: hepatitis A and B are safe, pneumococcus is safe, meningococcus is safe, chickenpox, here they are saying it's contraindicated and here they are saying it's safe. Influenza, that is flu shot, that is it's given in trimester 1. COVID-19 in trimester 1, it's safe. Given in special circumstances: if traveling to endemic area, yellow fever and polio. Note: air travel safe for pregnant women, not recommended after 36 weeks of pregnancy. Aviation restriction. Physical exercises: 30 to 45 minutes walking per day recommended in all pregnant women. Severe physical exercises contraindication in pregnancy induced hypertension, cardiac disease, patients at high risk of preterm labor, placenta previa. Nausea and vomiting in pregnancy. I have taught you this in 2 different videos, so please go and read that video if you want details. Those notes are from Toronto Notes. Nausea and vomiting in pregnancy, also known as morning sickness, is because HCG plus estrogen plus progesterone can be seen at any time of the day, peak at 10 weeks of pregnancy due to HCG peak, subsides by 16th week of pregnancy. Management: dietary modification, small frequent meals, avoid spicy and fatty foods. Drug of choice is pyridoxine 10 mg plus doxylamine 10 mg. Pyridoxine is coenzyme in fat protein carbohydrate metabolism and doxylamine is an antihistamine. If no relief, metoclopramide, promethazine orally. Last resort is ondansetron. So this is a very important management. Pyridoxine 10 mg plus doxylamine 10 mg. No relief, metoclopramide or promethazine orally. Last resort, ondansetron. Hyperemesis gravidarum: persistent vomiting associated with weight loss more than 5% of pre-pregnancy weight. Ketonuria: interferes with quality of life of patient, causes increased HCG, twin pregnancy, molar pregnancy. Risk factors: primary gravida with female fetus, high socioeconomical status, young females. Investigation performed USG to exclude twin molar pregnancy. Previous history of hyperemesis gravidarum: migraine, motion sickness, possible association with H. pylori, genetic predisposition, complication, dehydration, ketonuria, electrolyte imbalances, hyponatremia, hypokalemia, metabolic alkalosis, Mallory waist tear, vitamin deficiency, vitamin K, thiamine, vernix encephalopathy. Management: IV fluids for dehydration, thiamine supplementation, correct electrolyte imbalance, H2 antagonist, ranitidine or proton pump inhibitors to prevent acid reflux, antiemetics, no hypovolemia, oral drugs given, dimenhydrinate, diphenhydramine. If no response, metoclopramide, promethazine. If no response, ondansetron. Hypovolemia present more than 10 weeks, IV ondansetron may lead to cleft palate if administered. Less than 10 weeks of pregnancy. Less than 10 weeks of pregnancy, combination of 2 IV drugs, metoclopramide plus promethazine. If no response in more than 2 weeks, IV ondansetron. So ondansetron we try to avoid it. PUQE scoring for assessment of severity of hyperemesis gravidarum. 4 to 6 is mild, 7 to 12 is moderate, more than 13 is severe. Other ailments in pregnancy. Supine hypotension syndrome. Symptoms: dizziness, lightheadedness on lying supine, usually late third trimester. First sign is maternal tachycardia. Pathology: pressure of gravid uterus on inferior vena cava in supine position, decreased venous return, decreased cardiac output. Maternal hypotension may cause fetal distress. Management: lie in left lateral position. Varicose vein presentation in lower limb, vulval varicosities, hemorrhoids. Pathophysiology: increased blood volume, increased femoral venous pressure due to pressure by gravid uterus, increased vascular resistance, progesterone, a smooth muscle relaxant. Management: varicose vein, conservative, avoid standing for hours, use compression stockings, elevate lower limbs while resting, lie in left lateral position, no medical surgical done during pregnancy. Hemorrhoids: increased fiber plus fluid intake, local anesthetic gels, anti-inflammatory for pain. Vulval varicosities, vulval compressions. Lag cramps causes due to accumulation of lactic acids and decreased magnesium levels. Prevention: massage, hot shower before going to bed, improve hydration, extend knees and dorsiflex the toes during cramps. Carpal tunnel syndrome: numbness and tingling in thumb, index, and middle finger due to compression of median nerve. Management: symptomatic treatment, apply wrist splint, avoid corticoid steroid injection, and surgery. Bell's palsy, commonly seen, causes perineural edema, hypercoagulability, immunosuppression. Management: short-term glucocorticoid treatment, avoided during organogenesis as it causes cleft lip and cleft palate. I have made another video about a patient who was pregnant and developed Bell palsy and how we treated them with steroids. So please go and watch that video for the dosage and more details. Backache: due to laxity of joint due to estrogen, relaxin, weight gain, faulty posture. Hyperlordosis. Management: correction of posture, elevate lower limbs while resting, use of hard bed, back massage, analgesics. So that was antenatal care, and in our next video we will continue for